Hi, my name is Friedemann Zengerling. I'm working at the urologic department of the Ulm University. I'm specialized in urologic oncology and have been working on testicular tumors for several years. So it's a pleasure for me to give you this lecture today on testis cancer. Here you can see a short outline of the topics we would like to discuss today. First, epidemiology and tumor biology of germ cell tumors, risk factors, pathology, biology, and classification of germ cell tumors, therapeutic options in stage 1 seminoma, clinical stage 1 non-seminoma, therapeutic options in the metastatic disease, and therapy-associated morbidity. Testicular cancer represents about 1.5% of male neoplasms and 5% of urological tumors in general, with an incidence between 1 in China and 20 in Denmark per 100,000 males per year. An increase in the incidence of testicular cancer was detected during the 1980s, particularly in the northern European countries, where a clear trend towards an increased incidence has emerged in the last 20 years in the majority of the industrialized countries of North America and Europe. However, there are surprising differences between the incidence rates measured in neighboring countries. For example, a high incidence in Sweden and a much lower incidence in Finland. Data from the SEER program show a continuing increased risk among Caucasian men in the US only for seminoma. Epidemiological risk factors for the development of testicular tumors are a history of maldesencent testicles, previous testicular cancer with an absolute risk of 3.1% within 20 years, a family history of testicular cancer, especially if first-grade relatives are affected, congenital abnormalities of testicles or penis or kidney, summed up as the genitourinary system, Klinefelter's syndrome, and infertility in general. About 5 to 10% of GCT patients have a history of cryptorchidism. Cryptorchidism itself is associated with a tenfold increased risk of testicular cancer, even if these men underwent orchidopexy, that is the proper surgical therapy of cryptorchidism, before the age of 12. Testicular cancer generally affects young men in the third or fourth decade of life. It normally appears as a painless, unilateral mass in the scrotum or as a casual finding of an interscrotal mass. Only in about 20% of the cases, scrotal pain is the first symptom. Currently, diagnostic ultrasound serves to confirm the presence of a testicular mass and to explore the contralateral testis. Its sensitivity in detecting a testicular tumor is almost 100%, and it plays an important role in determining whether a mass is intra or extra-testicular. Serum tumor markers are prognostic factors and contribute to diagnosis and staging. The following markers should be determined. It's AFP, which is restricted to non-seminoma because it is produced by York sac cells. Beta HCG, the human chorionic gonadotropin. It's expressed by trophoblasts. And LDH, a marker of tissue destruction, which is recommended in the diagnostic workup of metastatic disease. So what do we know about these markers? Globally, there's an increase in these markers in about 50% of patients with testicular cancer. AFP increases in about 50 to 70% of patients with non-seminomatous germ cell tumors. A rise in HCG is seen in about 40 to 60% of patients with non-seminoma. In seminoma, up to 30% of patients may present or develop an elevated HCG level during the course of the disease. The definitive diagnosis of malignant germ cell tumor can only be reached by surgical inguinal exploration with ligation of the spermatic cord at the internal ring. The procedure will be presented in one of the following slides. So this picture shows a typical clinical presentation of testicular cancer. Left-sided testicle is enlarged, palpation is mostly not painful and reveals an indurated mass. Clinical examination also includes palpation of the groins. To rule out atypical metastasis, for example after scrotal surgery in childhood, which leads to a connection of the intertesticular lymphatic system with that one of the scrotal skin, which drains into the inguinal lymph nodes. Further, the palpation of the supraclavicular region is mandatory to rule out distant node metastasis that can occur in advanced disease. So this is a typical sonogram of a malignant testicular tumor. It shows an hypoechogenic, that means darker than the surrounding, inhomogeneous mass within the relatively uniformly configured testis parenchyma. The parenchyma can be interspersed by microcalcifications. That are attributed to be the sonographic correlate of testicular intraepithelial neoplasia, the precursor lesion of invasive carcinoma. Ultrasound can also be used for a gross workup of the retroperitoneal space that typically harbors lymph node metastasis close to the large vessels in the case of metastatic disease. The large vessels are the abdominal aorta and the inferior vena cava, which is not clearly shown in this sonogram. This arrow shows a small lymph node metastasis of about 1 or 2 centimeters right to the aorta. So as I said before, every patient with a suspected testicular mass must undergo inguinal exploration of the testis within his tunics. Immediate orchiectomy with division of the spermatic cord at the internal ring must be performed if a tumor is found. If the diagnosis is not clear, a testicular biopsy for frozen section histological examination can be taken and decision can be made on the frozen section result. As you have already seen in the sonogram, carcinoma in situ is the precursor lesion of invasive germ cell tumors. Germ cell tumors can be classified into seminomatous and non-seminomatous tumors, reflecting their origin in primordial germ cells and their ability to differentiate in vivo. Most non-seminomas include multiple cell types, and seminoma may be a component. When seminomatous and non-seminomatous areas are both present in a tumor, management follows that for non-seminomatous tumors, since these tumors are clinically more aggressive. Therefore, a tumor is diagnosed as seminoma only if the histological results show pure seminoma and if the serum concentration of alpha-fetoprotein, a marker exclusively of non-seminoma, is normal. Seminomas account for approximately 1/2 of all testicular germ cell tumors and occur most frequently in the 4th decade of life. That means later than non-seminomas. So now we go on with some facts about tumor genetics in germ cell tumors. Germ cell tumors are nearly always hyperdiploid and are frequently triploid or tetraploid. Hyperdiploidy implies that chromosomal endoreduplication is one early event in the germ cell transformation. Germ cell tumors have at least one X and one Y chromosome, implying that transformation occurs in a germ cell before the meiotic anaphase. An isochromosome of the short arm of chromosome 12 is a specific genetic marker of germ cell tumors and has been identified in all histological subtypes and in carcinoma in situ. Candidate genes on 12p include KRAS, CCND2, and NANOC. So, what is the typical pattern of metastasis in testicular germ cell tumors? Regional metastases first appear in retroperitoneal lymph nodes before the renal vessels. Right testicular tumors usually metastasize to nodes between the aorta and the inferior vena cava. Left testicular tumors metastasize to nodes lateral to the aorta so-called para-aortic. Superiorly, the lymphatics empty into the cisterna chyli, sometimes leading to retrocrural and posterior mediastinal adenopathy. So now we go on with the classification of testicular germ cell tumors. For the correct classification, the post-orchiectomy tumor markers and a CT scan is mandatory to classify the patients in one of these three groups shown here. The Lugano classification is a clinical classification and it groups the patients into a clinical stage 1, where the tumor is confined to the testis without radiographic evidence of metastasis. Clinical stage 2, which can be subgrouped in 2A, 2B and 2C, depending on the size of the retroperitoneal lymph node metastasis. Clinical stage 3 is characterized by supradiaphragmal lymph node or visceral lesions or metastasis in other organs. Of note, the cure rates in clinical stage 1 testicular cancer is almost 100%. In 1997, the International Germ Cell Cancer Collaborative Group defined a prognostic factor-based staging system for metastatic testicular tumors. Based on the identification of some clinically independent adverse factors. This staging system has been incorporated into the TNM classification and uses histology, location of the primary tumor, location of metastasis, and the pre-chemotherapy markers level in serum as a prognostic factors to categorize patients into groups with a good, intermediate, and poor prognosis. As you can see, seminomas are due to their less aggressive behavior, never poor risk. Fortunately, the 5-year overall survival rate has improved during the last 1 or 2 decades, as you can see by the Survival rates given in red. That have been presented at the 2013 ASCO meeting by Gundgaard and al. Clinical staging is based on the following diagnostic tools: serial blood sampling of AFP and beta HCG and lactate dehydrogenase LDH, as well as abdominopelvic and thoracic computed tomography scan, sometimes also abdominal and retroperitoneal ultrasound.